This is a lecture of pediatric hydrocephalus. I'm going to talk about what is hydrocephalus and the neural fluid. This one's called the cerebrospinal fluid, and I'm talking about the neural fluid dynamics and the pathogenesis of pediatric hydrocephalus and treatment. So, what is hydrocephalus? The answer is it's the intracranial overaccumulation of neural fluid which causes brain dysfunction. There is some background and some mechanism works, and then symptoms and signs like this developed. It should be important. The ventriculomegaly does not necessarily mean hydrocephalus. Ventriculomegaly can be the result of some atrophic change caused by some neurological disturbance like inflammation or something. This can cause ventriculomegaly. And here is some index that shows the grade of ventriculomegaly. Evans ratio as a normal range is less than 0.3, and frontal occipital horn ratio, this is less than, the normal range is less than 0.4. Very basic tool for diagnosis of hydrocephalus is to routine check of the increased head circumference. Like this case. In this case, you will see here the head circumference increase over the normal range, and then still it keep going to increase. So you can easily diagnose this is a hydrocephalus. Now I'm going to talk about neural fluid. This shows the old theory of the production, circulation, and absorption of neural fluid. So it is produced in choroidal plexus and passing these anatomical structures, and then fluid goes out of the ventricle to the surface of the brain and spinal cord, and finally it is absorbed from the superior sagittal sinus through the arachnoid granulation. If some obstructive mechanism happened in the ventricle, the hydrocephalus develops, and it is called obstructive hydrocephalus. And if something happens out of the ventricle over the subarachnoid space or somewhere, it is called the communicating hydrocephalus. And depending on the obstruction site, the very characteristic pattern of the ventriculomegaly is observed, and you can judge or estimate from the MRI or CT scan. So this slide shows what we call the bulk flow theory. This is an old theory of the production and absorption of the neural fluid. The neural fluid is produced in the choroidal plexus, goes down to the third ventricle, fourth ventricle, then come to the subarachnoid space, to the subarachnoid granulation, to the superior sagittal sinus. However, this theory was now not regarded as the true neural fluid dynamics. Instead, neural fluid is now regarded to be produced and absorbed locally, and it can move, but it doesn't flow. So now we have to understand this new theory. The production of CSF is artery pulsation is the driving force to produce neural fluid from the perivascular space to the brain parenchyma. And the neural fluid is locally produced and absorbed. Neural fluid demonstrates the to and fro motion with artery pulsation, but doesn't circulate. About absorption, neural fluid is absorbed from the ventricle epicenter interstitial cavity, perivascular, and the neural space called glymphatic system, and the cerebral or spinal dural matter. And aquaporin 4 promotes the neural fluid absorption from the perivascular space. This is a new theory of the neural fluid dynamics. This shows the key principles of the new concept of neural fluid physiology. First, local production and absorption of neural fluid. Second, pulsation, that means the pressure of neural fluid is propagated. And third, neural fluid doesn't circulate. So neural fluid moves but does not circulate. Neural fluid pulsates but does not circulate. And neural fluid diffuses and the pulsation is propagated. However, neural fluid does not circulate. These are the new concepts of neural fluid physiology, and we have to understand this new concept. This is a theory of the mechanism of ventricular megany by the hydrodynamic theory, and somehow pressure plays a very important role. And this is the normal, the interventricular pressure and the brain parenchyma here, and the decreased cerebral compliance. Then the interventricular pressure increase, and then it causes increased cerebral pressure, and the ventricular megany follows. So if you do the ETV here, this increased pressure goes out from the ventricle, and the ventricle size shrinks. So now I'm going to talk about pathogenesis of hydrocephalus. So pathogenesis of hydrocephalus is influenced by the medical and economical level of the country. So this is just one example. And regarding the perinatal hemorrhage or post-hemorrhagic hydrocephalus, it's up to 20 to 30% of preterm baby can suffer from interventricular hemorrhage, and 70 to 90% will develop a severe interventricular hemorrhage. And among them, up to 50% will require some kinds of neurosurgical treatment for hydrocephalus. And post-infectious hydrocephalus is more common in developing countries. Hydrocephalus associated with mild meningocele, interventricular hemorrhage, or congenital origin is more common in children less than 1 year old. And congenital and tumor-caused hydrocephalus grow more common thereafter. These are the result of the pathogenesis of hydrocephalus. So, congenital hydrocephalus comprises about 1 in 10,000 births, and the number is said to be increasing recently. This is a guidebook we published about 10 years ago in Japan about the fetal hydrocephalus. So when we say fetal hydrocephalus, it usually means hydrocephalus diagnosed before the birth. And hydrocephalus diagnosed within the first 1 year of the life is called infantile hydrocephalus. Actually, this fetal hydrocephalus comprises this part: primary hydrocephalus, that means this hereditary hydrocephalus Dandy Walker and something like this, and the secondary hydrocephalus. This is a post-hemorrhagic, post-intrauterine infection. This causes a secondary hydrocephalus, or even after the birth, there would be some infection or hemorrhage that causes hydrocephalus. And on the other hand, here, when we say congenital hydrocephalus, this congenital hydrocephalus means this fetal hydrocephalus, and some part of the primary hydrocephalus are diagnosed after the birth. So this part of the secondary hydrocephalus diagnosed after the birth is called acquired hydrocephalus, interventricular hemorrhage, or the meningitis or other infections. So people often think the fetal hydrocephalus is equal to the congenital hydrocephalus. But if you look at this, you understand this is wrong. Fetal hydrocephalus and congenital hydrocephalus does not mean the same entity of the hydrocephalus. This MRI shows the typical finding of the hereditary hydrocephalus called X-linked recessive form of congenital hydrocephalus. This is the X-linked hydrocephalus and the most common form of the inherent hydrocephalus. And the mental retardation, spastic paraparesis, adducted thumbs are the findings associated with this condition. The different phenotype of the L1 combo abnormalities, there are the other L1 syndromes like shown here. And they often associate with crash syndrome, the corpus callosum hyperplasia, retardation, adducted thumbs, spastic paralysis, hydrocephalus. So it should be very careful about the female X-linked hydrocephalus family. It can be a carrier of L1 combo abnormality, 50%. So may need genetic consultation when they grow old and have a baby or marriage. They may need some genetic consultation. The treatment of hydrocephalus. There are two major procedures: the VP shunt or neuroendoscopic surgery. And the shunt system, including the CS diversion procedure such as VA shunt or VP shunt, VP this time is the ventricular shunt, and so on. The ventricular and peritoneal catheter, shunt valve. There's a variety of shunt valves shown here. And this is a setting of the pen shunt for VP shunt, and this is several kinds of shunt valves and ventricular catheter. And this is a program valve. This is a shunt system. So the ventricular catheter, shunt valve, and peritoneal catheter. So the VP shunt is a golden standard for the treatment of hydrocephalus. However, there's a serious major complication always associated: shunt insufficiency, infection, and overdosage. So regarding to the VP shunt infection, the frequency is 3 to 20%, and usually around 5 to 7%, depending on the institute. And usually the NICU, the baby, newborn baby, the infection rate is higher than other children. The risk factors: repeated shunt reconstruction like this. Many shunt systems are inserted with at the time of shunt insufficiency. And the age less than 6 months, preterm baby, duration of surgery. The longer, the worse. Causative organisms are coagulation negative staphylococcus. This is usually 56%. The staphylococcus aureus and gram-negative organisms. These are the causative organisms. And the timing, when it happened, usually it develops within 20 to 25 days after the shunt construction, and mostly within 2 to 3 months after the VP shunt placement. So you have to be very careful about the first 2 to 3 months after the shunt implantation. So another major treatment now we are always concerned is a neuroendoscopic surgery. And there's several kinds of neuroendoscopic surgery for the treatment of hydrocephalus. The most common is the endoscopic third ventriculostomy. This is called ETV. And there's called fluorescence coagulation or cauterization. Sometimes the fenestration works for the treatment of pediatric hydrocephalus. So this is a schema of the ETV. So you can insert the endoscope to the ventricle and then make a hole to the floor of the third ventricle, like this. This is the third ventricle. This is infundibulary recess, and this is the mammillary body. And you can make a hole using a balloon like this. So ETV creates new pathway, bypass, between the third ventricle and the vessel system. This slide shows a step-by-step picture of the ETV. So this is from the lateral ventricle. This is a foramen magnum and called flexus. Then the endoscope is inserted in the third ventricle, and this is the mammillary body. And here, this is make a small hole by opening in order to pass the balloon, and the balloon catheter is inserted and it's opened and make a hole, stoma here. And you can see the brainstem and the basilar artery from this stoma at the end of ETV. So ETV success score is created to predict the success rate of ETV. So you have to think about the age and the background etiology of hydrocephalus and the previous shunt. And each like this scored of 0 to 50. And this is the ETV success score, and this is the actual success rate of the ETV. And you will see there is good correlation in this ETV success score. So for example, this ETV success score age plus etiology plus previous shunt. This is the example, aqueduct 3 years, aqueduct stenosis, no previous shunt. In this case, 3 years, that means 1 to 10 years here, 0.40. And aqueduct stenosis, this comes 30 here. And no previous shunt, 10. So the total 40 plus 30 plus 10, 80%. So you can estimate, or you can tell the parents that the success rate of the ETV in this case would be 80%. So the indication of ETV is obstructive hydrocephalus caused by the pathology from the aqueduct to fourth ventricle outlet. And the success rate close to the adult in children over the 2 years old, 89%. The success rate of infants, especially those under 6 months, is regarded low. And the ETV success score can predict the success rate to some extent. Not always perfect. There is some dissociation, but usually you can estimate somehow. And the injury to the basilar artery trunk or branch could be fatal. And the mortality rate of ETV is reported as 0.2%. And there's also some complication rate. It's about 8%, and the permanent complication is to be the 2 to 3%. And post-op subdural fluid collection can develop when the brain mantle is thin. And sudden death caused by the stoma obstruction has been reported in the long term. Several years later, this can happen. The incidence is very small, but you can't ignore this possibility, and the routine regular checkup by MRI is required even after ETV. So now you have two choices to select or treat the hydrocephalus, VP shunt or neuroendoscopic surgery. And these are the factors influence which one you choose. The pathogenesis and the exacerbation is rapid or the slow, cortical mantle, how it developed, and the most important the age and etiology. And it has been well recognized that the surgical result of UTV in children under 2 years, especially those under 6 months, is poor. And it is reflected on UTV success rate, as I mentioned before. So, when you face which one to choose for the treatment of hydrocephalus, you need to think about these factors. For VP shunt, it remains as golden standard for the treatment of hydrocephalus. And the advantage that you can use VP shunt for any type of hydrocephalus. Disadvantage, the foreign body in the body is VP shunt and can lead to the complications like shunt obstruction, infection, and sometimes overdosage of the neurofluid, which causes the subdural fluid collection, slit ventricle syndromes. On the other hand, neuroendocrine surgery, especially ETV, can be indicated in some cases of obstructive hydrocephalus, and the advantage is the treatment without shunt, no foreign bodies, and the permanent effect can be expected by a single surgery. Disadvantage is that no indication for the communicating hydrocephalus, and low success rate in infant, and technically it's more demanding than VP shunt. This is a summary of pediatric hydrocephalus. And hydrocephalus is a condition that overaccumulated neurofluid in the brain, mainly at the ventricle, leads to ventriculomegaly and subsequent brain dysfunction. Recent findings suggest neurofluid is locally produced and absorbed. Pressure generated by pulsation is propagated, but the neurofluid itself doesn't circulate. Neuroendoscopic treatment of hydrocephalus has been applied more recently, in addition to the traditional VP shunt. However, it does have limitations, and the surgical indication should be carefully decided. Thank you very much for your attention.